He initially put it in terms of a little bit of a TED talk. And so because he was so inspiring, I actually thought I'd tell you a little bit about my background, kind of why I did oncology and how I kind of got to where I am today. So I think in some ways similar to Alfredo, I actually also come from immigrant backgrounds, as many of us do. And so my dad was from immigrants from Sicily and Italy. And my mom's parents were very Irish, and they came from kind of the potato famine years. So they were here for years and years prior. And so my Irish grandfather was a New York City cop, and the Italian side were really all had lived together in the garment district and had all worked together to save up money to send my dad to medical school. And so he ended up in a general practice, delivering a couple of hundred kids a year, setting bones in the office. I have vivid memories of actually boiling syringes because my dad would go out and make house calls, and they were boiled in the home pot. And then he'd go out and make house calls, and my mom would re-sterilize them in the spaghetti pot, and kind of he'd go off and make calls again, which is kind of hard to believe considering where things are today. What I can tell you is the key part of that background, that along with the fact I also was one of 8 children within 12 years, and we had one bathroom for the children, which is why I also get up early. Because I really did want to be out of there before anybody else was awake. But one of the requirements really in our house was that you knew you had to get essentially A's in everything, because otherwise my dad would not accept it, because that was kind of the way out of the slum that he had grown up in terms of everyone living in the same house in Brooklyn, to get out of the garment district. So it was really expected to do that. And so initially, the idea was that I was going to go with my sister, who's also a physician up in the Bronx currently, and that we were supposed to take over his practice, which was this kind of other general practice. Well, that didn't happen, and that didn't happen really for a pretty significant reason, because we also have other experiences outside our family. So one of the things that really influenced me was the first person that I had a crush on in grade school actually ended up getting an osteosarcoma in about 6th or 7th grade. And when she did, it was, somewhat devastating. We got together and we had, a good friendship, but, I was a kid. But she also ended up being the first person I knew who died. And so she ended up dying of the osteosarcoma when I was in high school. And I just remember she had on the casket the John Donne poem, basically "Death Be Not Proud," and I was extremely inspired by that. And as soon as I got to medical school, all I wanted to do was study oncology. So during first year med school, I actually read the entire DeVita textbook back and forth. I just knew I wanted to do oncology, and always assumed that I'd end up doing medical oncology. With that, though, I did a rotation in radiation oncology and just loved it immediately. I loved the technology of it. I love the fact that every single patient's treatment was unique. It was specially designed towards them. And it wasn't just mixing a group of chemicals that then you changed and you applied to the next. And it seemed to me that, at least in medical oncology, I was frequently giving a group of drugs, and it was kind of a formulaic. And if that didn't work, I changed to this formula. And if that didn't work, I went to the next formula. And it didn't seem like I had quite as much chance to either I could do something or I couldn't do something, which I actually thought was a better way to approach it. I also thought I could do better research from the radiation oncology sphere. So with that, I ended up getting double boarded in internal medicine and radiation oncology, and started my career at the University of Florida. And I started working with Bill Friedman, who really is a very brilliant person who got me introduced into radiosurgery and some of the capabilities of radiosurgery that really went along with my previous training. But the key part of what influences me from a philosophic approach to science is this, and this actually did come from my father, because he very frequently would say this to us growing up. Enough that I can tell you, I knew it, but before going into college and graduate school, and I can say my children certainly have heard this at least 50 times. But it really is, I think, one of the true things in science and in discipline that you can learn. And that is that the wise man is really the one that knows what they know and what they don't know. And more so what others know and what they fancy they know and do not. So if you can go in and really recognize where you don't know a whole lot and work with experts in it, I think you can bring so much more to bear from multidisciplinary care, whether it's bringing in biologic expertise or computer engineering expertise or physics expertise. Because, frankly, when push comes to shove, I'm kind of a dumb doc, and I just go along and I really try and learn what I can to help my patients. But I can bring all that to bear if I really harness the energy of everyone's insights into the area. And so I would say that most of my career, I've tried to do that. And most of the really smart people are the people who've been around. So with that, what do I know? So how does radiation work? We know that essentially radiation attenuates as it goes through the body. If you add beams from multiple angles, you can summate them. And that led to kind of basic conventional radiotherapy, conformal radiotherapy, and everything else to come from it. We'll just go through some very simple slides. I think most people know this. It goes in, you reach a dose max point, and then as it goes through, a single beam will fall off. And this is a schematic in the brain as to how that might work. If you have two beams and you had one coming in from one side, one going in from the other, they start summating, and you can get an area that has a higher dose, and everything else out in this periphery is going to end up with a lower dose. And if you bring in multiple beams from multiple different angles, you can actually get a concentration of dose where everything's been summed, and over a fairly short gradient, you can get down to, say, 40, 50% of the dose around that. And I think radiation oncologists know that. Most, I think, neurosurgeons and other scientists know that. But the reality is even though we know that about how radiation works, when I at least started my training and going into this field, this is kind of what we were left with. We might be able to get a CT or MRI that showed some of these images, but I could only do a conventional simulation in which I got this, which would be a lateral or an AP film. And I would have to go back to that previous image, look at the radicule, get a piece of yellow sticky paper, map out how many centimeters it was from the bone, try and figure out on these films where in relation to the bone the tumor started and ended. Then I do a measurement using the radicules on the plane simulation film to develop what I would call a tumor contour in the AP and lateral films. And I always tell everyone I probably lost about maybe 2-3 years of my life really doing this whole process manually of going through making these tumor contours. Then this is circa about 1995, you actually even use solder wire to go through and you'd manually calculate, computer would calculate these doses on this, but this was really generated from a solder wire contour and what you got off those plane films to come up with a dose distribution. Clearly something that you say, well, that must be, eons ago. This is, maybe 25 years ago, but it really is rapid evolution in terms of how the field was applied. So virtual simulation in 3D really revolutionized everything because you could go directly to the image. And probably the more important thing with that is that you could move to doing off angles. So you could start using beams from not just AP and lateral films. And I actually did try this once on a plane film using sine and cosine to try and map out a tumor. And just let me tell you, it was absolutely horrific to try and figure that out. The 3D simulation, though, again, it let you use a whole bunch of different angles, so you could actually start deploying the ability to actually deliver beams with lots more than just simple beams. Despite this, all during my initial faculty career, even with 3D, you were still left to triangulation, where you were using a laser in a room and you were kind of mapping it up to a mask, and there's still a fair amount of radiation therapy that may do this today, that really doesn't have a high degree of accuracy. So it was in the midst of that environment that I ended up being exposed to, well, actually, let me drop back. So that this is the distribution you get. So if you look at this conventional therapy, why did it work so well, and why was most of the field based on it? The real reason is that the radiation therapy was based on a basic biologic principle, which is fractionation. And so despite not necessarily being very technically accurate, if you could get it around the area and give multiple doses, the early responding or tumor tissues at lower doses would be more sensitive in terms of their effect. And the late responding tissues or normal tissue around it, particularly in the brain, would be less sensitive. And if you did this repeatedly, you would realize the therapeutic benefit. So really, most of the success of radiation therapy over its early career were really predicated on this biology of fractionation, more than the ability to really target the radiation particularly well, or knew what we knew about how the radiation worked in terms of summating it or getting it to really concentrate to the area that we wanted to. So it's in this environment, despite kind of all of that previous radiation therapy history, that stereotactic radiosurgery came along. And it was really a neurosurgical concept that Lars Leksell developed in 1951, where he really set the precedent on its edge and said, you know, we're going to use radiation like a knife, and we're going to ablate an area with that. And instead of using this fractionated principle, we're going to essentially use the technical capability of concentrating a very high dose of radiation to a very specific area. And so using that paradigm in which you really could take an image, it really depended on being able to take an image, directly link a stereotactic coordinate frame to the brain, and then identify a group of voxels that you wanted to ablate or treat, and mathematically coordinate them and deliver it with, on the order of, you know, with the initial devices, on the order of 3/10 millimeter accuracy, using that type paradigm. So it was a complete difference from fractionated radiation. Again, not relying anymore on this biologic principle, although there are obviously biologic principles involved, but rather really it was applied with this technical selectivity. This extended, and one of the reasons I really moved to the University of Iowa was to try and more broadly do this. It's been directly translated into using real-time image guidance during the time of delivery. And we now have stereotactic body radiotherapy, stereotactic radioablation, spinal radiosurgery, all of which rely on using very high resolution imaging, a lot of times with very high dose perfraction treatments, to ablate and deliver a much higher dose to a specific area. The big difference with this, and some of the science that I think is most important with it, is that all of it relies on imaging for its targeting. So what I want to really spend the rest of the time on is some of the research we've done with the quantitative imaging network that goes to some of the basic problems that we face. And one thing we do in radiation oncology and in any kind of image-guided surgery is that frequently we're in a position where we may be given a set of images, and you can see this schematic image of a this was actually a craniopharyngioma in which they gave the images to a group of neuroradiologists, to some radiation oncologists, and to some neurosurgeons, and said, outline the target. And what you can see with all these different lines here is that you got a range of different uses and a range of different tumors, which means that we really, as a field, as human beings, can't ideally consistently identify what our target is. And what's even more concerning, and it's just the truth of human nature, is I know that if I went and outlined this target or some other target that I might have, and you took it away from me for a month, and then you brought it back to me and asked me to outline that manually, I'm not going to identify exactly the same target. And while we all know that we're experts, that has to be the perceptual nature of being human, makes you not perfectly consistent on any given day in terms of identifying or perceiving these targets. And it's just not necessarily the most reliable way to do this. So the quantitative imaging network tried to say, well, can we use quantitative imaging and the information within imaging for clinical decision-making by making better tools really founded on, frankly, at a very basic level on mathematics, to very consistently identify targets, or for that matter, identify response, because a lot of oncology decision-making is also based on what the basic response of that tumor is. This is our initial outline of what we set up at the University of Iowa. And what you have is a clinical data going in. You also had all the images going in. And most of the paradigm was done with a head and neck data set, but it applies to any site that you can imagine, including brain, obviously. So we got clinical information on the one half, on the top, all the de-identified images on the other. And in this, we have PET-CT images for this. We developed a segmentation manager, and working with computer engineers, developed some computer algorithms that we're going to talk about, and then looked at and compared that to what manual segmentations might lead, and how that might affect the outcomes in terms of treatment delivery for radiation therapy. These were ported into publicly available venues such as 3D Slicer, and some of the tools we developed are there. Our data set is actually also publicly available on the TCIA, and they're being used in a number of different applications with interdisciplinary groups that develop pipelines. So that actually the Stanford group has taken the data set and ported it into the IROC, which is the Radiation Oncology Quality Assurance, and they could actually port the entire data set over to actually evaluate some of the outcomes of the segmentations that we get. So let's just jump into some of these tools and talk about some of the problems. So this might be a PET image. It shows the structure that we want to outline. If we can outline that and we have a full volume, the other interesting thing that we can get, and if we can identify it consistently, is we can get far more than just the outline of the target. We can get all kinds of different metrics and radiomics metrics of that information. So we know about SUV max, peaks, averages, metabolic tumor volumes, but there were also, you could look at the top 25%, what's the hottest 25%. We've been very interested in looking at the fringe region of this in terms of its overall prognostic significance. And you can get a range of 50 or 100 or 1,000 different metrics out of any given volume. And you can do that for every tumor if you can do that in an automated way in a data set. The key parts of this is that why don't we frequently do that? Well, the reason we don't is because currently a lot of what we have had to do is rely on manual contouring of our data. And to do that, again, it's not only is it inconsistent, it's also massively time consuming to try and get all that information into a computer system to do calculations. So problems with it are the complexity of it, and then we also need to get normal tissues. So let's start about some of the work working with computer engineers. And this is what our baseline premise leads. If you do something completely manually, it basically takes a high level of effort. And if you look at the variability, it's also high. If you completely automate it, it should take virtually no effort, and you should have virtually no variability. And for some things, like normal organs, in fact, this may be possible to achieve. And you can for instance, I'm going to show you an example of cerebellum, where you can get the volume, generate all the information you want from it, and you can do that in a completely automated way. Just feed it the image, and the algorithm can go and get it. Now, if you look at a whole group of different tumors to try and find them and categorize them completely in a completely automated fashion, becomes much more difficult, and it gets into computer-aided diagnosis. But if you have the physician, say, just identify the center of a given tumor, that becomes a much more faster, and we call that just enough interaction. And we've used that for a number of our tumor modeling using a graph search algorithm that Milan Sanka has really developed, and that's called deep logismos through that. So here are some of the examples. Again, I'm going to concentrate and just show the example on the cerebellum, but we could also do this with the aortic arch or liver, and we can do a fully automated segmentation of that. Initially, we used this active shape model, where we took a whole group of different cerebellum. We manually had contoured them, and then used that to give the computer information to logically know where the cerebellum was, to be able to find it, and then come up with a contour of it. So we feed it basically knowledge based on what a manual contour could give, and then it can generate a mean shape and give you a volume along with it. Frankly, we've redone this, and AI does a better job with that if you look into some deep learning methods. And so we even do better in terms of identifying the contour. I'm going to skip ahead because I am worried about time. I want to make sure I get through this. We had a large group of scans to test this. They were consistently applied to scans that were obtained here. So they were high quality scans. The experts traced a large number of them manually and then compared them to the algorithm. And this is really the take-home message. It's the this is the 4-slice version and the volumetric version. And what you see in the black lines is that the algorithm in black, compared to the 4 different experts who contoured the cerebellum, you can see that it's very, very consistent with what we would identify, and yet it's completely automated. So rather than spend 4 physicians' time coming up with this cluster of various colors, you can see the black, the algorithm can get you that essentially very, very quickly. It also is substantially more consistent. So if you look at the variability of it, the cerebellum, both 4-slice volume and aortic arch, were statistically significantly more consistent, and they were in line with what the expert would do with essentially increased speed. So a substantial improvement. There's really no reason that we should be doing manual contours of such structures. Now, to get to tumors, again, I said it's a little bit more complicated. And so what you do is you can get it, if you identify the center, the algorithm can then give you a sphere. And then what it can do is it can look for the greatest fall-offs along that sphere using a number of different nodes. So it's actually looking for a surface. This is not a simple thresholded method. And it can find you that surface and then automatically calculate all of the metrics that I told you if you wanted to look at radiomics metrics. but it's complicated, right? If you look at a chain of lymph nodes, things are right next to each other. So, working with computer engineers, we developed some splitting algorithms of these. We also have things like necrotic nodes, and so there's a separate button. If you click, possible necrotic node, it'll basically allow for that and try and find where the necrotic node edge is. And then it'll automatically calculate these range of different radiomics features in an automated way. So you do have to spend some time with the images going through identifying each node that you want contoured, but it can give you a sophisticated look at all the different nodes, and then you can generate all these metrics regarding them, and you can look at how that relates to the overall prognosis. So we did that, and furthermore, you can see in this, we also normalized it against the cerebellum using the completely automated matrix. So this predictive value, just using the initial PET scan alone, gave you an AUC predictability of 0.875 for, this is a fringe value, normalized against cerebellum of that outside area of the tumor volume on it. This is the specific validation test we did. There were 60 cases with 230 lesions. We had 3 investigators randomly contour, where we would do, one case manually, we do the next case using the tool. We went back and forth and then compared it against the other, and found that the manual versus semi-automated method, that the semi-automated method was much more consistent in terms of dice coefficient compared to if you had 3 experts doing the various volumes on the PET imaging. And furthermore, if you look at the time, the semi-automated took about 1/3 the time overall to be able to do this. So if you're dealing with a large number of image sets, it also does have editing capabilities. So the other thing I didn't talk about with this, but the next example will illustrate it, is that you can also edit in 3D. So rather than going on a slice by slice basis and having to edit every single slice, you can go through and hit a point and it'll edit the entire volume in a 3D manner, and then you can just review it to speed the process. This is an example. And again, we actually said, look, we want you to get this node and this node and this node, and this is the way the experts did it. Okay, this is expert 1 against themselves. And then if you gave the same information to the same docs using the semi-automated method, they would accept these values the same way. So while we worry about editing and being able to do it, if you give physicians a tool, and if it gives them a volume, their ability to say that's acceptable or not actually makes it much more consistent than it would be otherwise. I'm going to show an example of a different tool we developed for meningioma based on similar graphs search principles using deep logismos. And we tried to look at very complex meningiomas where the speed would actually be sufficiently beneficial because contouring some of these large skull-based lesions certainly is quite time-consuming. You can see here there's a red sphere that goes around. You basically identify the center of what the tumor volume looks like, and it will find you a volume virtually immediately. Now, this wasn't necessarily ideal, so you can go and edit it. So this shows an example where you wanted to add an area here, so you hit one point at the edge, and it edited that in 3D, so that essentially picked up an extra volume just on one click by doing that. And that shows the example. And again, I don't have a movie to go through, but it does do this in full 3D.
And John, just a quick question about that particular one. So you're doing this, in that case, the tumor comes to the optic nerve and potentially close to the chiasm. So do you have the ability to just click a point and say, I want to isolate or do a little bit less right here against this corner or this nerve or something like that? Is that much faster as well?
Yes, you can definitely do that. So you can definitely take your contour and push it away and actually get it to pull down away from critical structure as well. You definitely could do that. This shows an example where it really missed a significant amount. And the algorithm isn't great if you actually give it something like this and just try and click out here. It won't find this whole area. So sometimes we would have to do a second sphere to pick up another bigger area, but then you can have it combine it. And that works as well. So that's another tool we created for very complex shapes to be able to get the entire volume. And that was just recently published. So the last thoughts that I really wanted to bring as we do this, because to me this is kind of what's near and dear to my heart about this, is that we in radiation oncology and a lot of what we do in terms of image-guided surgery is we based our tumor control probability on a whole group of manual contours that particularly in terms of a national trial type basis, you may have a whole group of different people outlining. And again, I think I've shown why that in some ways is fundamentally flawed. But when it comes down to it, if you then take it a step further and ask yourself about tumor control probability, how do we really know what tumor control probability is? And the big, I guess, fear about using algorithm has been, well, what if the algorithm's wrong? And one of my questions has always been, well, how bad or how wrong does the algorithm have to be worse than the humans doing it the way we're currently? And even if it was worse, and it was consistently worse, would you actually be able to at least know that it's worse so that you could fix it in the long run? Whereas now the way we do it completely inconsistently, we can't even figure that out because we just continue to do it manually with this variability that doesn't enable us to really effectively ask that question. And so we're trying to statistically get at this through a kind of a simulated exercise of, what if you added biases to a knot by difference amount? Because I think it really does end up being a statistical reality that an algorithm will have to be better long-term to identify these things. So my conclusions are know what you don't know. I think that there's an opportunity to intelligently apply computer-aided methods to medicine to improve our consistency, and that really doing that will translate into a better understanding of tumor control probabilities and normal tissue complication probabilities. And the quantitative imaging network has been a big part of really helping to develop tools so that we can use these for it. And ultimately, hopefully, that's going to translate into what we all care about, which is better outcomes for our patients. And it will be essential to real-time adaptation. So in order to do the type things that are coming along with MR-Linac and other things like that on a daily basis, you're going to have algorithms that are fast and able to actually get these things to change on a daily basis as things move. So I think I got it within my time, and I'm happy to answer other questions. Again, I am definitely the very small part of the smarts involved in this, and my colleagues in computer engineering are really big parts. Mike Graham had run nuclear medicine here for many years and was intimately involved in looking at a lot of the PET imaging, and the physicists in both nuclear medicine and radiation oncology have played a big part in terms of doing this. So I'm happy to answer questions.
Sunil and Dan are going to lead a series of questions right here. Go ahead, Sunil, and then take it away.
Well, nothing special. That was a wonderful talk, John. I didn't know the history of things until you spelled it out for us. A question for you. What are the operating parameters for your auto-contouring that limit why you're not able to move from cerebellum and aorta to liver? I treat GI tumors, so I know how challenging all of the commercially available software botches liver auto-contouring
Yep.
pretty badly.
Yeah. So we are actually applying. So we're in the process of putting a program project together, looking at specific paradigms for liver. We have one that's going to be applied towards prostate, because one of the things is you want to also be able to do prostate and the rectal area behind it for adaptive planning and be able to apply the just enough interaction. So I don't really think that there are limits, but you do have to customize how the algorithm is applied to those sites, because there's going to be different thresholds. So the whole barrier to actually getting this done, I think, in a qualitative way, is getting enough. You need a big set of really, what everyone would agree would say, here's normal liver, here's 100 examples of normal liver, to give it to the algorithms so that then they can use that to intelligently get you the rest. So we have a pretty well-developed things for bones in the pelvis, for some of the lumbar spine, for a number of different sites, but the liver is one that we're actively working on.
Thanks.
I have a quick statement and a question. First, great talk. Love the history stuff, and it kind of demonstrates. So I go to a lot of these neurosurgery lectures with Q, and the recipe for a good neurosurgery lecture is to talk about Harvey Cushing, and then some history stuff in neurosurgery, and then relate it to current practice. And I just want to bring up that, like, I think it's easy to think of radiation oncology as a specialty that's set in stone and cannot be improved. And the benefits in cancer therapy are going to be in biologic agents. And I think we would agree, but I'll say it out loud, that it's short-sighted, I think. And not just in that we can improve radiation oncology, but that we can integrate it better with the other agents that we use for cancer therapy. And that's something that we bring up in this conference. But and so it's exciting to see this, and that I just want to explicitly bring up that the advancements that you described really are focused in radiation oncology, but they have obvious implications outside of it, into diagnostic radiology or neurosurgical decision-making or follow-up scans or whatever. And I think one area that's exciting me is, like, for growth, and I assume you're doing this, but maybe it's too difficult, is you've showed data on PET imaging and on some MRI stuff. Can this algorithm evaluate multiple diagnostic series at the same time, like a CT
Yes.
and an MRI and T2
Yes.
plus T1?
Yes, yeah, particularly. So Jiadong Wu is one of our computer engineers that's also shown and has some direct information using both CT and PET, and there's no reason you couldn't also use MRI, and we're probably going to use MRI and CT combined in some of the prostate examples that I was giving you, and you can use some of the deep learning methods to actually use the mutual information from both to get a better answer for some of these contours. So that's definitely being done. I didn't show some of the examples of that, but it definitely can and is being done.
And to follow up on a question, and I think Dan raised it, one of the challenges that we have, John, and Dan knows this, is that we have all these patients, we follow them, we present them in conference, we're there with neuroradiology, and I don't know if anybody in neuroradiology is here right now, but we're constantly, has the tumor grown? Whether it's a meningioma, the easy ones, of course, well, nothing is easy, but the relatively less complex are the meningiomas, convexity, all right? But most of the time we still, well, it's 2 by 2 centimeters or 2.2 by 3 centimeters or whatever. But the reality, so now we are having some of our fellows just do manually contouring and tracking them and stuff like that. But why couldn't your technology that you device and be used exactly for what Dan said, to be able to monitor growth, to be able to make decisions? The meningiomas being the less complex, but the gliomas potentially now encompassing the contrast versus the, the flare and and figure out how do you normalize also the scans that you do? What are your thoughts about this?
Oh yeah, absolutely, and interested in that. So you know, we are looking at gliomas, starting to develop algorithms specifically for them, and then how do you use the multi-parametric information? How do you use the information both from the contrast enhanced image, the FLAIR image, some of the diffusion weighted imaging. There's, you know, work out of Michigan using high B value information. There's information looking at spectroscopic information. And ideally, you'd like to be able to merge all of that information together to be able to inform you, is that tumor progressing or not? And can you do that in an intelligent way? And I absolutely think that that's what we need to be doing, but we need to get much bigger data sets. I think one of the things that I'm always surprised by, even though we have all these patients, that to get the algorithm, to get it to do all the information and to get a really nice, clean data set, it has been harder to do than most people would take on. Another major thing that I do think becomes challenging is, you know, it's not just, if we did that in, let's say, a set of 100 or 200 gliomas here at the University of Iowa, well, that's good. Well, what if we then took that algorithm and applied it to a group of images that had been, you know, obtained across the country, perhaps with slightly different acquisition parameters on the MR imaging, or slightly different voxel resolutions, or some changes within that? Does it still apply? And I think there are challenges there too, in terms of how the acquisitions and the consistency of the machines are QA'd. So there's a lot of really basic work to be done in this area that I have no doubt will translate into better outcomes if we can actually harness it and get it done consistently.
Well, I know from our side, we're definitely interested. Go ahead. I think that someone was about to ask a question. Go ahead.
Sorry, Dave Miller, I don't, I know that some of my colleagues who do more imaging than I am are here. I think, Q, your point is well made, and there should be definitely opportunities. There will be challenges in the imaging of the tumors that have already been treated, as we already have the challenges in differentiating, you know, areas and edges of necrosis and edema from what's active tumor, and how these things sort of grow finger-like and things. But certainly, you know, with as our speaker mentioned, with larger data sets, I think that those things can be perhaps overcome or certainly managed to some extent in the future. I mean, there certainly are a lot of opportunities to do that kind of stuff following that way, but there will be challenges, I think, in treated tumors because of the way they change and what we're, especially with, you know, the limitations of the different modalities in determining just the state of tissue, especially at the edges.
And John, so just so you know, Dave is one of our neuroradiologists and also interventional radiologists. So he's got a lot of years of experience. So, yeah. And you know, but that's a challenge that we have, all right? I mean, just going back to the time, I mean, just looking at your grants that you have right there, your NIH grants, you know, assessing response to cancer therapy. And we sit in these tumor boards, and I would say probably 100 tumor boards going on around the United States between all the major academic centers. And we don't really have a standardized way to assess either, as you said, how we should treat a patient with radiation oncology, or how to assess growth, or how to assess response. It's all over the place right now in the United States. And I see opportunities for us. And this is what I wanted to see, whether we can engage more between our sites, because I know you have already very strong collaborations with Rochester, with John Sarkaria and the group right there. Now with Dan and of course Sunil right here, I see us, you know, potentially involved in that aspect as well.
Yeah, no, we would love to, and you know, I think that there's some good potential opportunities. You know, certainly to collaborate. We're very interested in that, and I know my colleague Brian Allen presented some of the other work that we're also doing in terms of basic glioma work. So I think we can collaborate on both fronts.
Absolutely. No, Brian did a beautiful talk. Everybody, so you guys remember, Brian is in John's department, and we had him here a couple of months ago and did a beautiful talk as well. So, Well, thank you, John. We're very, very excited about all the work that you're doing. And I just, on a personal level, I just want to thank you also. Remember you and I talked about what it was like for you growing up. And it's important for our younger generations and our senior generations to understand that we are all in the same journey, and that what you're doing is inspired not only by your personal experience with your family, but also with your friends, as you said. And I was just so touched that you wanted to share this with our team right here. Very excited. I look forward to, hopefully we'll have you in person. And
yeah, I would love to.
That was my plan.
Yeah, absolutely. It would be fun. I would love to.
So good.